So welcome everyone. Today's topic of discussion is breaking bad news. I think this is one topic which we all have to face at one or the other point. And I'm not sure how many of us actually get any formal training in breaking bad news. Especially clinicians, I want to ask you how many of you have had a real formal training in breaking bad news? Raise your hand if you have had any proper formal training.
No formal training, but we have learned from
Learn. So
some
the
some
problem is,
resources.
yeah. But the problem is a lot of time when the breaking of bad news is done by somebody who's not very experienced, they really face the music, and we see a lot of aggressive reactions coming up when we break the bad news. So before we go further, I want to ask everyone, what do you think? What is bad news? What is bad news? Neha, can I request you to come in? Please have your camera on because we are just six, seven of us. So it's better if I'm able to see all of you. सत्य प्रकाश आप भी अपना अगर कैमरा ऑन कर पाए तो बहुत अच्छा होगा. बैठ के कर लीजिए, कैमरा अभी बंद कर लीजिए, बैठ के कर लीजिए. ठीक है? ओके. और आप कुछ बोलना चाहे सत्य प्रकाश तो बोलिए, हिंदी में भी बोलिए, बिल्कुल कोई दिक्कत नहीं है. फील कंफर्टेबल, यू मस्ट.
नहीं नहीं मैम, ये क्लासेस हमारे लिए फॉर्मल नहीं है। काफी चीजें हमें सीखने को मिलती है, काफी चीजें हमें न्यू लर्निंग के। हाँ, ये इतनी बारीकियों में भी जाना जरूरी है। इस माइक्रो लेवल पे चीजों को समझने के लिए ये क्लासेस जरूरी है मैम।
Good that you are liking it. Thank you so much. Yes, I want to ask you, what do you think? What is bad news? What is bad news?
Bad news
For
basically is
when
an
people don't
untoward
practice,
outcome,
Okay.
which is not expected
Not
also
expected, not
read by the
anticipated.
party.
Okay. Thank you. What else? What else?
when
Death,
people are not ready for
Life
whatever
changing.
life changing. People are not ready for. Yes. Death, complication, and some untoward
big
reaction.
loss मैम,
हाँ जी, बोलो बोलो.
big loss।
Big loss. अगर कुछ, if there's some complication, some loss of health, loss of limb, that also is a very big this thing. So I want to share my experience of bad news. I'm talking about almost like maybe 25 years ago, you can say so. So I had suddenly, cough, cold, difficulty breathing, and also pain in my lower chest. And I mean, for 1 or 2 days, I just took some simple medicines, and I mean, I was okay. Then suddenly, I asked my husband, I said, no, let's go and consult somebody because it could be, something serious. And we went to one of his friends who is a physician. So he said, he examined and he said, I mean, I can hear some sound, but then let's get the X-ray done and then see what it is. So once he saw the X-ray, he said there's some shadow, on the lower lobe, and he started with the medication. And he said, "Okay, let's hope that it is nothing serious, and you will be fine. Otherwise, we'll have to investigate you for tuberculosis." That's what he said to me. And the moment he said all this, for him, probably it was a very regular thing, nothing very big. Trust me, after I came back, both my daughters were very young at that time. Elder one was like maybe 10 years, and younger one was just 3, 4 years at that time. And I was really very, very upset with this, that who will look after my children, who will look after their studies and food, and will they be able to sleep with me, will they be able to come close to me, will we be able to share our meals. I had 110 concerns, although we all know tuberculosis is curable. I mean, you have to just take your medicines and take your diet and rest, and you look after yourself, and there's nothing very serious about it. But that was one experience, for 2, 3 days I was so low in myself that, I mean, I really was, for my whole thing, my whole world actually came, crumbling down. Thankfully, after 3 days, when we got the X-ray done, it was clear and there was no shadow, and my symptoms also subsided. He said it was just simple, maybe infection in the lower this thing. No, but then you are fine now. So see, for us, we think bad news is when you talk about death or when you talk about cancer or something. But honestly, if somebody tells you that you have diabetes, or you have hypertension, or you have rheumatoid arthritis, or you have migraine. I mean, these are also very serious diagnoses. And we normally, because we are doing it every day, so we think it's a very small thing, it's a regular thing. Only when we are personally affected by it, that is when probably we realize that it is not a small thing. I have seen, mothers literally fainting when they get to know that one of the child's eye is amblyopic, or their child is high myopic, especially young kids. My husband is an ophthalmologist, so a lot of time I see, kids like 5 7 years, when they have some vision problem, and teachers ask the mothers to go and get their child's eye checkup done, and when they get to know the child is high myopic, they are literally crying and howling like anything, as though something very big has happened. So the point I'm trying to make here is that we think it's only death and complication and something very serious. That's actually one part. But the real part is, for example, I'm sure during COVID time, all of us had COVID. How many of you thought that we will not be able to make it? And especially those of us who had serious symptoms, very severe symptoms. Fever, cough, cold, chest pain. I have had relatives who were very seriously ill. They were admitted, they were hospitalized, and for them, that's a trauma that's still with them for very very long time. So we will do a small, role play. I want you to do a small role play where I want maybe since we are, how many of us are there? We are 9 of us. So I'll be putting you into breakout room, 3 in each room. So that means we will have 3 breakout rooms. Okay, but then excluding me, then you are 8. So maybe in 2 groups you will have 3 members. So one person will play the role of the doctor who is going to break the bad news. The second one will be the patient, and the third one to be the patient attendant. And I will give you 5 minutes time to go into the breakout room, and I'll just first share the situation. Let me share the screen with you, and share the situation so that you can see what situation we are going to take as a okay. Can you all see the screen? Okay, so one of you will become doctor, the other one will become patient, and the third one will be the attendant. In case in a group where there will be only 2 members, then we will have patient and the doctor. We will not have any attendant. So you can take a situation where the patient is a young, adult who's been diagnosed with CA pancreas, and the doctor has to break the news to the patient. Assume that it's a diagnosis that has been made after all deliberation, after all investigations, and now you're very sure that this is what is the, and try to play the role of the patient. I mean, if you had something like this, what questions you will have, what will be your emotional reaction, and how would you feel? I know it's role play is more an artificial kind of a situation, but just try to get into the role. And the person who is breaking the news, try doing it in the best of your capacity, communicating. So I'm going to create breakout room. Individually you will be able to decide who will be playing the role of the doctor between you, and 5 minutes are okay. 5 minutes are okay. So सत्य प्रकाश, आप जिस ग्रुप में होंगे, आप पेशेंट बनिएगा, और जो आपके साथ पार्टनर होंगे वो आपके साथ डॉक्टर बने, और अगर आप 3 लोग हुए तो एक अटेंडेंट। मैं आई एम क्रिएटिंग ब्रेकआउट रूम्स।
जी मैम। मैं थोड़ा सा अपना रोल जानना चाहूंगा कि क्या क्या मुझे करना होगा उसमें।
सत्य प्रकाश, अगर आप पेशेंट हैं, है ना, अगर आप पेशेंट हैं, और अगर आपको कोई बताता है कि आपको, गॉड फॉरबिड, मैं मतलब इसको उसकी तरह लीजिएगा, रोल प्ले की तरह, कि आपको अगर कोई बताता है कि कैंसर है, तो कैंसर का अगर मुझे पता लगे तो मुझे कैसा महसूस होगा, क्या क्वेश्चंस होंगे मेरे दिमाग में, मैं क्या पूछना चाहूंगी। और इसमें आपसे ज्यादा डॉक्टर का रोल होगा, जो आपको वो न्यूज अनाउंस कर रहे हैं, वो कैसे करते हैं, क्या वो आपके कंसर्न्स को एड्रेस करते हैं, क्या वो आपकी बात, आपकी फीलिंग्स को समझ पाते हैं। ये बेसिकली हम चाहते हैं कि आप एक्सपीरियंस कर पाए। So मैं 3 breakout room create कर रही हूँ. So in 2 breakout rooms there will be 3 members, and in 1 breakout room there will be 2 members. So I'm creating the breakout room, and 5 minutes time you will have. Yeah. So you will yeah. So you will have to join the group by yeah. Please join. Yeah.
going to have
Um, do we have to start again?
No,
Or
you were still
Oh,
not.
we'll come back.
were we visible when we were discussing?
No,
No.
no,
Okay.
no.
Okay. Neha. So, hello, Neha.
Hello.
Now the role play is over.
Role play is over. Okay.
Yeah. Have you done it? Could you all do it? At least part of it?
Yes.
Yes, we've done it completely.
Okay. Okay. So can I request everyone to come in so that I can see? So I want to ask, first of all, those who were playing the role of the doctor, how did it feel to be there? Keep it brief. I want everybody to share their experience. Since we had just three groups, so I think all three people can speak. But please keep it brief so that everybody can share their experience.
It's difficult. It's difficult to break this such a news to a young lady uh, who's full of hopes and all that. But we have to do it.
We have.
That is our responsibility. But
Yeah.
we should do it softly, and we should try to give some hopes.
Okay.
That is what we should. I
You-
was thinking, and I was trying to that it should not. Well, the patient should not feel that is the end of the life. Like if she
We
was
have to
asking me
balance.
all the time how many days I have left, so I
Yeah.
was avoiding to answer that question.
It's so difficult to actually address that question because one, we don't have very clear, a lot of time we say we have just few weeks, but the patient lives for longer. Or we may say it's all right, you have enough time and there's, you will be able to come out of it, but then we have conditions where we have metastasis and then we know probably a patient does not have much time. I completely agree, and it's difficult to actually give a very specific timeline on that. Thank you for that. Yes, Dr. Siyog, I think you were talking to Satya Prakash. So what were your, how
Yes,
did you feel being there? Yes.
Yeah. So one thing uh, I think so. Most of the doctors or health professionals would be facing this thing that when we want to break news, we
Hmm.
know that our breaking, if we are telling them the thing that they have something like uh, pancreas right now. Uh, so we know that this is going to hurt the patient, and we also want to put it in the format which the patients uh, they'll understand in a better way, and also we don't want them to lose hope. So that thing was there
Hmm.
to think about the words, to not hurt him.
Hmm.
So
So
we were
unless you are
thinking,
really very good at, words, you
yeah,
don't get the right word. I by chance I entered your,
yeah,
room, breakout room. So I could
mm,
see that you said you are positive, but then you couldn't exactly say that. I mean,
yes.
what is positive? Is it the report positive or the possibility positive? So I completely understand what you are trying to say. And in the
So
third group, who was playing the role of the doctor?
Myself.
Okay. So Jayapriya, what was your what how did you feel to be there? Please understand my question. How did you feel to be there?
I'll tell you that I've faced the situation so many times, especially see a pancreas I've seen. And when it comes to cancer,
Hmm.
I mean, that's what I've been taught as well, that, you should not utter the C word, is what my chief used to say when I was in training. So the moment, even if it's a very curable early stage cancer, the moment you utter the word cancer, it just disheartens people. It's a death sentence. So I try as much not to utter the C word. Even
Hmm.
in the conversations in front of the patient rounds, we use mitosis, something that is, camouflaging. So in my patient Mariam and her sister Archana,
Hmm.
they were trying to ask me, of course they didn't too much ponder. I kept telling them it's a growth. I said it's a tumor, and then I said it will spread. And they didn't. Generally I do that when I talk to my patients. I don't utter the word unless I'm pressed and they ask me on the face, is it cancer, doctor?
Hmm.
I push them to it, and then I say the word. So it's very, very difficult. And there are times that they understand, they don't want the word. They will start saying, should I undergo chemo? That's
Hmm.
what Mariam said. Should I, how many cycles chemo and things like that. So it's very, very difficult, I'm telling you.
Again, Dr. Jayapriya, this guidance or the guidelines you received from your senior that don't use the C word. Now I want to ask all others also. I mean, if the patient actually has cancer and if you don't use that word, can you not tomorrow be blamed for not being very clearly, mentioning about it? And then say, I mean, patient might say that you did not give me complete information, or you withheld information, or you did not tell me what exactly the condition is. Because you did not tell me this, so I never thought that it is this serious, and now you are saying it is. It is. I'm not sure. I mean, how far it
Not
is.
only the legal aspect, madam, it is unfair on our part to hide some information, mitosis and all that. These words we should not be using in front
Yeah.
of the patient because they're jargon, medical jargon.
Jharkhand,
So we
yes.
have to speak in a language the patient understands. And
So
if it is cancer, you have to.
Mitosis is the word I used to discuss with my colleagues when we are in front of a patient. That's
So,
what
Dr.
I'm saying.
Jayapra,
No,
the
we
thing
are
is,
talking to the
this
patient
is
right
a
now.
technical word. What you are talking about is a medical term, which you know what is mitosis. But the patient does not understand. So tomorrow they may blame you for not coming out honestly with the information. And
No, you have misunderstood this whole thing. What
Hmm.
I was trying to say is when we discuss among colleagues in front of patient attenders, we don't say cancer.
Okay, okay.
Discuss
With
with
the
some
patient,
other
but
medical
with the
jargon.
patient, but what with the patient? You have to
With
tell.
the patient, what happens, madam, we live in India.
Yeah.
Okay, and we deal with a variety of patients from low social to high, well-educated, and in the entire spectrum. And we have to deal with their emotional, what do you call it, where they come from. Even if a well-read person is very anxious, apprehensive, they just break down. And there's an entire spectrum there. So my perspective, because I deal with CA stomach, CA colon, CA breast, and things like that. So during the process, when we say biopsy, during the process, they understand. And along, if it's breast, they in first thing when they come with the breast lump is they ask if it's breast cancer. But many other cancers, they may not expect. And what we see is even if it's stage 1 cancer, many times the attender only knows. The patient doesn't know. And there are times when we've told them it's cancer. It's not exactly hiding. It is telling them on their face that it's cancer, because I worked in Cancer Institute as well, and I found that it's very, very rude. The first thing the doctor says, the chief doctor says is, look at cancer diagnosis. The first thing on the face, it just demoralizes them. So my perspective here is, if they ask me upfront if it is cancer, I say yes. And cancer is only a word. And what it means to you or me or to anybody in this group, it is not what it means to every common man. For common man, cancer is death sentence. Even at stage 1, very early cancer, completely curable, whatever it is, cancer means death, and they're going to die. And they start dying from that day. And we have patients with, please,
Yeah, no, it's okay. I think Jayapra is talking out of experience.
I'm not saying it's good to hide.
Yeah,
what
but
I'm
at the
saying
same time,
is,
I think the point we are all trying to make, Dr. Jayapra, although we respect your experience and your expertise because you are in the subject, so you are handling this, but we have a feeling that there is always a risk if you don't clearly come out with the diagnosis and let them know that this it is. There is
Hello, ma'am. Hello,
patient
ma'am.
part.
Doctor, I want to share something. Well, what she is saying is, when you disclose to the patient that you have a cancer, his immune system goes down further, and the chances of recovery do go down. What you are saying is that, then is it right medico-legally? In such situations, what I have been doing, I have done a lot of cancer cases homeopathically. We used to do only have cancer patients on that day. In a day, we used to do 10, 20 patients. So in such cases, we used to tell attendants, where we found that the relative only didn't want to disclose, because if they said, if my wife comes to know, she will break down, and then the chances of recovery will go down. So in such cases, the husband or the mother or the father was disclosed, but the patient was told, okay, don't worry, you will get well, just take this medicine. So this also was a help.
Exactly, Dr. Neha.
No,
That's what
Dr.
we
Neha,
do.
I think again, Dr. Neha and Dr. Jayapra, we will not go into this discussion because this is something Probably one, of course, there's a medical legal aspect of it. If we are infringing on patients' rights, and tomorrow you can be in trouble also in case if the patient gets to know. And this risk request that don't tell the patient or don't tell my family member. We will talk about it, and we'll have more discussion on it. Dr. Siog has a point to make, and Dr. Mariam has a point to make. So Dr. Siog, please go ahead and share your experience. Yes, whatever you want to say.
Yes, ma'am, it all depends actually on if we are at which stage of the cancer right now. If we are right at the diagnosis level, at that particular time, when patient does not know if this is just a growth or then when he goes, and then when we have to break this news that yes, the report for cancer growth is positive, that is when I think so the apprehension and anxiety is the maximum. uh, when, say for example, if in that first stage, first diagnosis, if it is say it's negative, but the oncosurgeons or the onco physicians, they feel that we would require further more culture and biopsies and everything. So they may go, and then some advanced tests are being done, and then the patient is again waiting. He's thinking that it should be negative, it should be negative, and then unfortunately it is positive. That's when the doctor has to break the news, and that is where I think so you have to tell them that yes, that this test was done for this, and it is positive. We can say the same thing. We are not saying that you have a cancer, but he knows that the test was being done for this particular cancer. So we are not saying that you have a cancer, but we are saying that the test results are positive. That is somehow
I get your
we
point. Yeah.
tried to.
So, Dr. Siog, I think I'll conclude this discussion here because we have to go further and cover some more details about this. How do you go about doing this? What I understand, of course, to straight away just say that you have cancer and your report says that you have cancer is not the way to do it, because that's not how you should be delivering such a serious news. Even if it is stage 1 or stage 2, 3 or 4, that's irrespective of that. That is one thing. Second is, yes, patients should know what I have, but that can be, the news can be staggered. It can be saying that yes, we can see some growth, but we need to confirm by doing maybe FNAC or maybe some biopsy or some test, and that would tell us more clearly what exactly the situation is. And patients are intelligent enough to understand that if we are investigating on these lines, that means, and every time if we are going for the second test and we are saying that I think we need to further confirm it, so that means we are also not very confidently saying that no, it's clear. Because otherwise, if it is clear, you would immediately say I think everything is all right, nothing to worry. But when you don't use these words, they do get the message. But at some stage, I think it's very important to even inform the patient. If it is cancer, patient should know I have cancer. Why I'm saying this? See, although we think, one reason is we think the patient will break down and the patient's recovery will be affected. But if the patient knows that I'm going to die, it's patient's right to know that I'm going to die. Patient may have 100 things on his mind that the patient wants to do before I die. If I know I'm going to die, maybe I have 10 things that I want to do. Maybe I want to apologize to somebody. Maybe I want to talk to somebody. Maybe I want to clarify certain things. So that means I get that chance to take that. Of course, the support the family provides, the support the healthcare providers provide, how you handle those emotional issues, how you address those concerns is very important. But just to cut short that and not to handle that, if we say it's better not to tell the patient or to the family and just treat the patient, is not a good idea. Patient should know, the family should know. If the patient wants to make a will, if patient wants to give something to somebody, wants to apologize, wants to discuss, want to clarify, I think we should give that chance. And we have a tendency to underestimate patients' ability to cope up with the situation. Very honestly, if you are able to provide right guidance and balanced support, they are able to cope up with it. And then, I mean, if one has to die, they should die gracefully. That's what I think. Because I've seen patients, and of course, like you said, Dr. Jayapra, as you said, some people break down. Yes, I've seen that also. Even with the benign growth, their anxiety and panic level will be skyrocketing. and they would assume that I'm going to die. And I've seen patients who are in this fourth stage of cancer, and they say it's okay. I want to fight with it. Let it know whom it has affected. I mean, I've seen extreme, and I'm sure you are into the subject, so you know it equally well. The idea is we are not just only breaking cancer as a bad news. It could be diabetes, it could be hypertension, it could be, OCD, it could be a psychiatric condition, it could be autism, it could be anything. But everybody has a way to process the information. Are we with the patient in that processing? Are we helping the patient process? Are we able to explain to the patient about whatever their concerns are? And like that, Dr. Jayapra said, information needs. Some patient wants to know in detail, and some patients do not want to know at all. You will have to assess, and how ready are they to receive the information and accept it, that you will have to evaluate. So it's an individual case, and it's not like one line answer that you have to tell this in one go and so that means, but the idea is that we have to be mindful of it, that the patient might be very upset or may go into panic. That's the whole idea. Now I want to ask the next question to the people who were announcing this. Again, please keep it brief so that we can go further. What were your concerns when you were trying to break the bad news? So, Dr. Praveen, I think you were one of the person who played the role. What were your concerns when you were breaking the news?
The first concern was that how the patient is going to take it.
Okay.
That is why we normally start with how much patient knows.
Yes.
We normally begin with it, and most of the times when we are so much investigating, the patient has got a background idea that he is having. So gradually break that thing.
Yeah.
And at the same time, you can always ask that do you have some relative in front of which we would like to discuss this case, any support or something. And then after that, once you have to give that bad news slowly, gradually in a soft way, but give it very clearly.
Yeah.
There should not be any ambiguity about
There
it.
is no ambiguity. Absolutely.
And after that, if the patient breaks up, then give some time to patient to
I'm
vent
talking
his
about what were your
emotions.
concerns. One concern you said that
Yes, my concern was this only, how the patient is going to
wonderful.
take it.
Dr. CEO, when you were breaking the bad news, what was your concern? Maybe one concern you can clearly point out.
It was the main same what Dr. Praveen had said. It is how the patient is going to take it.
I was going to see it. Yeah, absolutely. Dr. Jayapriya, what was your concern?
Yeah, so in addition to what Dr. Praveen and Dr. Suyog said, my major concern after that would be, the true thing is I don't have all the answers. They'll say how many months I'm going to live, how many cycles chemo do I want. Actually, we don't have an answer. So yeah, that is, and
how do I articulate that? I don't have an answer is a very difficult thing to admit to the patient, that I don't have a straight away answer. But is it really impossible to admit that I don't know? I'm with you in it. I am with you in it. And we will assess time to time and then take a call. Right now, this is one step that we have to move further. We have to start with this and how your body responds to chemo. And after a couple of chemos, we do the reassessment and we see where we are. And then we take a call. Can we not admit this? Because we are not gods. We are
actually, honest communication and say, and they say, suppose the survival for this particular cancer is 80%. We can't say the patient belongs to the 80 or the 20.
Yeah.
So in such case,
admitting your vulnerability, though it is difficult, but is it impossible? Why not? But if you are able to say, I'm with you in it, we will work it together. I'm keeping an eye on your progress. I'm keeping an eye on the development, and we will scientifically decide what we need to do further, whether we go for surgery or chemo or radiation. But I'm with you in it. I think that's the major concern. Okay, now I want one more question for three of you, and then I'll come to the patient party and the families. What were your challenges when you were communicating? Dr. Siog, one challenge that you had when you were communicating.
It's the challenge, I would say, not anticipating, how the patient is going to, take the bad news. Probably, and I did not. I mean, although I was equipped with answers to give him clinically, but I do not know. Now, since he's speaking to me in Hindi language, I can still have, I can console him, or I can maneuver him emotionally also. But if he's speaking Telugu or any other language which I do not know, I am not comfortable. In that case, it would have been very big challenging for me. So that is one thing I think. So, and so that maneuvering of that emotional
I think handling emotion is a very challenging task. Handling
Yes,
emotion
yes,
is a very
absolutely.
yes, Dr. Jayapriya. What do you think was your challenge when it came to sharing the news with the patient?
Yeah, so when I was sharing and she asked, I said that we need to do further staging to see where it has spread and things like that. So it's just now we did a CT, you want one more CT. The challenge here was, the trust goes down when you say we need to do one more test and one more test, and to convince them and to, kind of tell because this is one category of patients is difficult because they become suspicious, probably because
Why
their
would this become
finances.
suspicious, Dr. Jayapriya?
When you do test after test, see, in cancers, one is to establish diagnosis. We do a series to establish diagnosis. Then from there is just a starting point. Then we need a series of tests to see where it has spread and to stage it. And then only we will plan the treatment. And the challenge here is one person can't answer. It's usually a multimodality. So one person doesn't have all the answers. So the challenge usually is they'll say, just now we done a CT scan, just now you did a biopsy, now you want us to do one more test. And there could be financial concerns, then they might be frustrated.
Again, it's not, when you say patients' trust would go down, but if I can explain why I need to go for the second test and what is the reason why I think that the second test is required, and I don't think patient will lose trust. Rather, patient will trust you more, that you want to be 200% sure before you actually reach to a conclusion.
Dr. Indo, all patients are not like you. Okay.
But I think again, if
Yeah.
I can, if no, again, see, if I can help the patient know, like you said, that I can't answer alone, I need to discuss with my team. Why can't I tell to my patient that, see, I can see this much, but I have a team of people who can see the same situation from different perspectives. Once I have their input, I think I'll have more clarity on your case. Again, it's about admitting that, admitting your vulnerability. Probably, I'm just trying to bring up that to all of you. A lot of time we want to show that I'm super confident of what I'm saying. Why can't I say I'm not very confident? Like when we started this session, and I said, let's call off, let's not do this session today. But when Dr. Suyog raised that concern that we can't go on like this and we can't keep postponing, and even I take out time, I immediately said, I go with what you say. What I'm saying, that we have to actually shed off that image that I know all, and I am the one who will be deciding. If I say it's not just me, I have team of people, and it's always good to have people on board, because then I'm able to see things which I'm not able to see when they give their input. When you say this, I think, I feel patient will have a lot of confidence in you, that you're not doing it alone, but you have people who are collaborating with you. Then your patient will definitely be very sure of what you are talking. Try doing this, admit that I don't know 100%. Every day things are evolving. We have radiologists who are very experienced, very knowledgeable, and we have pathologists who are very knowledgeable, very experienced in their subject, who can tell us, yes, this is cancer and this is not cancer. If you have them on board and you admit that it is not one person who is making your diagnosis, but it is a team of people, I think your patient will have far more faith in you. Yeah. That's what is my understanding. So, how many of you had difficulty finding the right words to communicate? I'm talking about challenge. 3 of you are finding the right words. Yeah, I think that's also one challenge.
Yes, I found it difficult.
Yeah. So I think that is something
Right
also
word.
we have to learn to find the right word. And vocabulary plays a very big role. And if we know that I remember I was doing this session for interns, breaking bad news, and I said, okay, your patient has to undergo amputation. Also, how will you explain to your patient? I mean, they were saying they were fumbling with word, and they said, "आपका पैर मर गया है, उस पैर को काटना पड़ेगा." That means we need to know how to even put those messages in right words. Vocabulary plays a very big role. Command over language is very important. Whether you explain in Hindi, English, Telugu, Tamil doesn't make a difference. But can we find better words to communicate honestly? I think that's one thing I think we need to really work on. Now I'm coming to the patient party. Dr. Seema ji, I think you joined late, so you don't have the idea that we have already had a role play and we are discussing that. But you can at least witness the discussion that we are holding. So who all were playing the role of patient? Please raise your hand. Okay, Mariam was patient, Satyapal was patient, and who else was patient? Okay, Satyapal was patient. Archana, yeah, I think you were attendant. Am I right? Yeah. And who was the third one? Who was it? Dr. Neha, you were also patient? Okay, Dr. Neha was patient. Okay, so as patients, how did you feel being there? How did you feel being in the patient's position? One by one. Okay. पहले अर्चना बोली. Mariam, you were patient, no?
Yes, I will tell.
Mariam, you go ahead. Yeah.
I felt very confused because she was not clear what she was telling that it's a growth. It's a growth. So I felt confused like.
So what did you expect your doctor to tell? Mariam.
I would like her to be clear and honest.
So you felt the doctor was not coming out with the exact word, and he was
And
not.
she was more communicating with my attendant rather than me. What I felt.
Okay, okay. So that's also another, and a lot of time we do this. We consider patient as a mute spectator of everything because we think it is the attendant who has to take lead in the treatment and care plan. Whereas communicating with the patient gives you an opportunity to build rapport and also understand how is the disease diagnosis impacting the patient. So I think Mariam has brought in a very valid point. Thank you, Mariam. I think both the points are very well taken. Now, what about Satyapal? आपको कैसा लगा जब आपके साथ डॉक्टर सियोग आपको बता रहे थे तो अपना एक्सपीरियंस?
मैम, जैसे ही सर ने मुझे बताया कि आपकी रिपोर्ट जो है वो पॉजिटिव है, तो आई वाज वेरी शॉक्ड, बट सर ने मुझे काफी रिलैक्स किया कि आप इसको घबराइए मत, सारी सपोर्टिव टीम आपके पास साथ में है, ट्रीटमेंट अवेलेबल है, और जहां तक पोस्ट की प्रॉब्लम आती है तो हम एनजीओ से भी कांटेक्ट करके हेल्प करवाते हैं। बट इसमें ये था कि मैं अकेला था, मैं भी अकेला था, और कि आपकी कोई फैमिली है या कोई सपोर्ट है जो कि जिनके साथ हम बात कर सकते हैं, सिर्फ एक ये पॉइंट भी रहा है, अदरवाइज बहुत सपोर्टिव टॉकिंग रही थी मैम इसमें।
So इसका मतलब है you were okay with the way Dr. Siog was breaking the news to you, and मैं by chance
जी मैम,
breakout में मैंने देखा he was trying to explain to you. So he could.
मैं जो भी क्वेश्चनिंग की थी मैम, मैंने जो भी क्वेश्चनिंग की उसके पॉजिटिव आंसर सर ने
जवाब
दिए,
दिया, एक्सप्लेन करा,
भी अवेलेबल है और सपोर्ट भी अवेलेबल है, और हॉस्पिटल आपको अगर ट्रीटमेंट हमारे पास नहीं होगा तो हम बिल्कुल राइट प्लेस पे भी सेंड करेंगे।
So if I go by
रेफर
explanation
करेंगे।
given by Satyapal, that shows कि patients expect us to talk about that aspect also. है ना? कि if the patient has a question, they want an answer. If patient has a concern, they want that concern to be addressed. So a lot of time when we break the news and we say, okay, this is what it is, and then we don't go further in understanding what their concerns are. So their questions are not answered, their doubts are not cleared. Then they may go for second opinion, and especially those of us who are little less communicative, your patient will have more challenge in connecting with you. Thank you, Satyapal, for that. Archana, you were patient's attendant. Yeah. So what was your experience as a attendant?
Like as Mariam was saying, the diagnosis, like it was like I mean, the doctor was breaking the news saying the diagnosis is not yet clear. We are yet to come to a conclusion. And also, like, we need to do more tests to get more clarity. But exactly, like, when we were asking also, like, to get a clear picture also, it was like we have to do more tests. We have already done biopsy, we are already done CT, but we have to do another test. So if the word have been said and if we have to do more tests, it would have been more clear as a because see, patient is there talking near, sitting beside me. I am talking to the doctor. Most of the questions I have asked to the doctor. Doctor was answering to me. My concern would be like I will be thinking a lot of other things like coming to the finances also. So my questions would be definitely like क्यों और टेस्ट क्यों इस टेस्ट से कंफर्म नहीं हो रहा है क्या, this kind of things. So when if the cancer word would have been, and I would have not thought of about all those things, and I would have be ready to all the tests whatever the doctor wanted to do, because I know it is very dangerous. I want to make it more confirm. I want to get a clear diagnosis so that we can plan it clearly. So this is what I felt.
Thank you. Thank you for your input. I think you were saying what Mariam has already mentioned, that if we knew the diagnosis clearly, probably we would have more clarity on why we are going ahead with more tests. Wonderful. Thank you. Yes, Dr. Neha, you were one of the patients. So how did you feel being there, and how do you think the whole thing went between you and your doctor?
I was just hoping he doesn't use the word cancer. I was very scared, and he did use it, and I didn't know what to say. But I just wanted to know, okay, how long is there now life for me, so that I can close matters before I leave the world, as you said, because there are a lot of things to do if I have to go, and I need to know how long I will manage it. So that was the thing.
Imagine, I think we have two exactly opposite opinions, Jayapriya. Like you said that, I mean, we don't like to use the word cancer, at least in the beginning, so that patients slowly become, comfortable and know that yes, there is something serious, and then maybe at the later stage. So we can see Neha was not very okay with the idea of cancer word being used for her, and that was not very comfortable and easy, and I'm sure it comes as a shock. I shared my personal experience very honestly. I'm sure you all must have had the same experience sometime in life, like even COVID gave us that experience where, I mean, when we had COVID, we all felt that will we survive, will we make it, will be all right, and what complications we will have, and what will be the ultimate outcome. So that means we have to balance. There is no one line answer to it. There's no one line answer to it, that okay, this is the way we have to proceed. We have to be very mindful of a lot of things. I think once I'll share the protocol with you, you will have more clarity on it. But I'm very glad that the discussion is really bringing in different perspectives. One patient may want to know everything, one patient may be too scared to listen to that. But Neha said, after knowing that I have cancer, I started thinking, what all do I want to do before I go? And I'm sure this must be everybody's. And even I have seen a lot of patients, their family members saying, don't tell my mother that she has cancer. Treat her, don't tell her that she has cancer, and let her go without knowing that she has cancer. I mean, I don't know how do you really, you really need to help the family understand why knowing that I have cancer. Dr. Praveen, yes, I think, and then I have two hands. And
medical ethics says that the patient is the first person who should know about it. Then he decides who other.
Yeah, rather actually. So again, see, we can't just blindly even apply this in our system. I know in the Western world, they ask the patient, whom do you want me to talk about your diagnosis?
Disease,
And whom do you want the person to be present when I'm sharing?
So so that is why we can't keep the patient in dark. The patient is the first person to be told about the
and
disease.
in India, it is exactly opposite. We just have the patient as a mute spectator and we interact with the family. But we can always evaluate and then take a call what will work in what situation. Of course, patient has to be informed. If the family says don't inform, then we need to talk to the family and counsel them and help them understand why informing patient is important. Not because it is medico-legally important for the patient to know, but why it is helpful for the patient to know that the patient has this and this is the cooperation. And in any case, patients get to know. So, I worked for adoption center for almost 10 years. I used to get patients for assessment and also pre-adoption counseling. So every time I will ask parents, do you want to tell the child that we have adopted you? Almost 100% of the patient will say, no, we don't want to tell the child. We don't want the child to know that you are adopted. So I respect their, intent. But then I help them understand that you are trying to hide a truth which cannot be hidden. And later the child will get to know, more hurt the child will be. If the child knows right from the beginning, child will be mentally ready for something like this, and you will see for the child it will be just like, it's okay, I'm fine with it. And most of them understand and agree that it's quite similar to that. We think the patient will be shocked, but then it's important for the patient to know. Yes, Dr. Archana, I think you wanted to say something, and then Mariam, if you have something to add.
Yeah, actually, there is another perspective where I deal with.
Okay.
Like what kind of breaking bad news I deal with. This must be something new to most of you, because I am not a doctor. I don't counsel patients about death or cancers or their diagnosis, but I deal with some other breaking bad news. I mean, that can be helpful to me. I mean, this session is helpful to me also. Like there is a premature baby, maybe a month old, has been staying in an ICU, and due to some complications, that baby might have expired or something, deceased. So I have to do a reverse counseling to that mother, how to stop her breast milk. 1 month back, I would have counseled her regarding how to increase, how it is uh, good for her baby, how it is like a medicine for her baby, encouraging her, coming her to and getting her to NICU, all those things. Now I have to go back and do the reverse counseling, like without help of any medication, how to decrease her flow, how to manage the engorgement, how to not get into mastitis stage. So I think this is also kind of breaking bad news in our profession. So it is like very, very difficult stage. Like, I mean, I feel very bad sometimes talking. I mean, few times to avoid, I tell them to you go home now. I will give you a call after 2 or 3 days, because I wanted to settle down first with that news.
Thank
so
you.
this is just I wanted to share.
Thank you. Thank you for sharing your experience. Seemaji, do you have any question or anything you wish to add to the discussion?
No, ma'am, I am personally, the field is breaking the bad news is really something, a very difficult situation which every day we are facing, nowadays. The main concern is the relatives, Patient is the one definitely who has to face all the consequences, but the relatives, who just accompany the patient, they really, feel the agony if the person is the only earning member of the family. So dealing with the patient and with the relative, is something very
Absolutely.
challenging.
Their concerns have to be addressed. Absolutely. Especially in our country, I think family plays a very big role in patients' recovery and treatment. So definitely financially, physically, emotionally, they are drained in the process, running, pillar to post. So definitely their concerns have to be addressed. Yeah. Thank you for sharing that. Yes, Dr. Mariam, you wish to say something, I think. Go ahead. Yeah. Yeah.
Yeah, my question is to Dr. Neha. She said she was scared to hear that word. So how did it? But the doctor uttered that word. So I wanted to know what was her feeling when the doctor uttered the, like, whether she felt supported or she felt relieved, or what was her feeling when she heard that?
I was like shocked. I was like, for a minute, I had no words to say. But then I wanted to know quickly, ke wo abhi kya? Now what? What have I got to do? Tell me the days, tell me the months, tell me the years. Is there any chances of recovery? Yes, sir.
Absolutely, absolutely. So just I'm taking you forward towards the presentation, because I have some facts and figures to share with you, and then of course the protocol that I want to share. Protocol is more like a guideline. There is no one line answer to any situation. We all have to deal individually and craft our own way of communication. But these guidelines help us understand the deeper intricacies of this whole process, because and probably this discussion that we had has also brought in the idea of the patient's perspective and the family's perspective. And of course, the task of breaking bad news is not easy. Incidentally, in this role play, all three of you are doctors, so you're already familiar with it, or at least you know it. If it was done by some non-medical person, probably they would have understood how difficult it is to do the breaking of bad news. It's not really very easy. So let me take you to the presentation and discuss, take the discussion further. And one second, yeah. So we talked about how you feel and how the patient feels. The patient perspective that says that patients actually value doctors who communicate clearly and empathetically. So whatever you say, even if you talk about cancer, as clear as cancer, but what is the overall communication, how empathetic you are, and then how you explain and answer their questions and involve them in decision making. So if it comes as a blunt information and no discussion, then of course patients are affected, because they feel it's a very suboptimal kind of an experience. Studies also show that almost 60% of the patients want to discuss about their life expectancy. And I think this is one question anybody will have the moment you get to know that I have a limited time on earth. The first question you have is, how much time do I have? Because that's how you want to start your reverse counting. But studies suggest that only 1/3 of the patients had actual discussion with their doctors, where they were told like what is the expectancy. Although again, there is no one strict time period that you can talk about, but some range they want to know, that how much time do I really have. Then again, 60% of them wanted to discuss the effect of cancer on their other aspects of life. What about my kids? What about my family? What about my parents? What about my job? What about my mobility? What about my general health and also other activities? But a lot of time we have seen that our discussion majorly focus on the disease and its treatment, and we don't go beyond treatment of the disease. So almost like 1/3 of the patient actually had the opportunity to discuss the effect of it on their other aspects of life. So this one slide, I'm sure maybe many of you must have seen. In this, they are carrying actually a patient's a diseased dead body. This is Kumari Komal Vadigare. So on the banner, what it is written, that this lady died because of the negligence of Dr. So and so, and this doctor should be punished severely. So again, I have a feeling when breaking of bad news is done in a more mechanical manner, a lot of time the patient families feel that they haven't had a fair deal. That's because breaking of bad news is one of the trickiest and most difficult communication, especially for example when you talk about death. Cancer is still okay, you can discuss, but suppose if you suddenly announce death, and if you have not prepared the family, if you have not talked to them, if you have not answered their question, they will see patient's death as your error, as your negligence. So that's where usually the communication breaks down and they become aggressive, and you will see most of the aggressive reactions happen when you break bad news in a mechanical manner. Especially younger generation experiences more challenges because they are not very apt at handling emotions, and that is where they lose their impact and also communication. Actually, breaking of bad news require advanced level of communication and also experience in handling emotions, and that's one area which we are not very comfortable doing. So one has to be really good at words, because that's where your communication gets seen, and also how you handle their emotions and also their questions, and how do you handle your own reaction to this situation. Because a lot of time if the patient party start blaming us for the outcome, or they say that we were not responsible enough, or you were not very, caring, and you did not attend promptly, or the patient was neglected. That's where you start feeling bad and, cornered, and you start reacting to it by justifying that you did everything and you were not at fault, and it's not your, you are not responsible for the death. That's where actual communication starts breaking down. A word of advice, I think, for every one of us is we need to build good rapport with every patient so that they trust us. They know that we are not willfully negligent, especially in cases, these cases turn into any, emergency, and there's an unanticipated outcome. If they have trust in us, we have seen patients collapsing after test dose, isn't it? And if we have the patient and the family has trust that we haven't done anything willfully, we haven't done wrong willfully, they will actually overlook this, and they'll say, they will not blame you for the outcome. And studies actually show we also do not create familiarity with the patient, and that's one of the reasons why the patient party feels that we are not careful enough. Studies have actually shown that patients are more likely to be aggressive with the doctors with whom they are not familiar. If you are able to create familiarity, rapport, comfort, trust, they are less likely to blame you for the outcome. And the best way to build rapport with them and also win their confidence is regularly updating them. Let them know what is being done, why it is being done. And then whatever concerns they have, it could be financial concerns, it could be like second opinion, it could be that they are not very, sure of the diagnosis, whatever their concerns are, they need to be addressed. And also when you involve them in decision making, rather than we deciding about them, just give them facts and figures and let them participate in decision making. And if you are able to involve them, usually they are satisfied that they are part and parcel of the treatment plan, and then they don't feel suddenly at loss, and they are ready for it. Of course, transparency and honesty has no substitute in your treatment protocol, in your management. If you are transparent and honest, they are more likely to trust whatever comes on their way. But then in case if we are not answering their concerns and if they are not addressing their concerns, they are likely to blame us for not sharing all the information. See, whenever the patient is in critical condition, for example, if the patient is in ICU, it is in critical condition, I think the greatest fear the patient's family would have is fear of death. And anybody's behavior will be very different when they are fearing death. They will go in panic, they'll be anxious, they'll be more, questioning, doubting, losing trust, trying to know more, trying to seek help, trying to get second opinion. So we have to be okay with this because that's how they want to do best to their patient. And that does not mean that they are doubting us. That should mean that they are trying to do their best to save their patients. And then, incidentally, we look after the patient very well, but when it comes to families' concerns, we are not really, very particular about addressing their concerns. So it's very important to remember, I would say patient is far more comfortable than the family. At least patient has a bed, medical attention, nursing attention, food, medicine, treatment. It is the family who is suffering more because they are draining in terms of their finances, their physical, ability, their emotional health. Everything is affected. Their days and nights are gone. There's not enough space to rest and sleep and, take their food and their, day-to-day needs. And they are the one who are emotionally, very overwhelmed, and that needs to be addressed. So as I said, I'm going to share a protocol with you, and this protocol is, it's just guidelines, and there are a number of protocols available. If you will Google search, we'll get to see a lot of protocols. You can go through, those that are available on net. That will give you a lot of idea and deeper understanding of how we need to be actually handling this situation. It's always good idea to break the bad news to be done by a senior most person in the system. A lot of time we have seen, junior residents doing it, especially in emergency. In ICU, residents we have seen doing this. if there is a senior most person present in the system, that person should be doing the breaking of bad news. Specifically, the person who has been handling the case, whoever has been the attending consultant, that person should try to be personally present when you are breaking the bad news, because patient party is more likely to trust and communicate with the doctor with whom they are already communicating, in the past. Now, this is, again, I'm talking about the protocol. There are 4 P's in the protocol. The first P is preparation, how you prepare yourself, where you do it, and how you prepare the patient. Second P is about performance, how you do it. Then palliate, how do you really take it further and plan the patient's treatment. So talking about the preparation of the patient, I think it's very important to be 100% sure of what you are going to share with the patient. A lot of time we have seen doctors going, half prepared in delivering the news, and then in the patient party ask some questions about some test that was done on the previous date, or some review, or some referral that was done to another doctor, and they may say, doctor, you had referred us to so and so nephrologist, we had gone and seen that doctor, so what is their opinion? And you say, oh, I'm sorry, I have not talked to that person. So they feel that you are not fully prepared for it. We have also seen sometimes one patient's report getting attached to another patient's reports. I'm sure you also must have seen that kind of error. And you go and, announce that this is what is your, diagnosis. And then later on you say, no, this was not your report. This was some other patient's report. So one has to be 100% sure of what you are going to say. Of course, making connection with the family, not on the spot, but through and through, I think we need to have connection with the patient and the family so that they feel that you are part of the team, and they are part of the team as well. Again, patient and the family may want to discuss at length about what it is, how this has happened, why this has happened, what is going to happen, what are the options available. And at that moment, if you seem to be in hurry or you seem to be occupied, they are not going to take it, in a good spirit. They will feel that you are not ready to you spend time, and also you are not taking their condition seriously. So you have to be really mentally ready to spend some time with the patient and the family. Interruptions like phone calls, visitors, somebody waiting outside, I have another case to see, I have to go to OT, I have to do this. Again, patients do not see this in a good light. It's always good to put everything on hold, especially if you're going to break any serious, news. You have to be mentally and physically there with the patient and the family. As I said earlier also, please do not delegate. If it is your case, you should be doing it. And in the system, whoever is the senior most person should be present when you are breaking the bad news. Of course, juniors can be present for the sake of observation, for the sake of learning. But the actual talking has to be done by the senior most person. When it comes to place, a lot of time in government setup, I have seen we do the breaking of bad news sometimes in the OPD or in corridor or outside OT, outside labor room, or near bed, inside ICU. That's not a good idea. It's always good to sit and talk to the patient party. So if you have a counseling room, there's nothing like it. But it makes sure that you sit and talk to them so that they feel that, we are getting that individual attention. And of course, I think in most of the good hospitals, we have counseling rooms where we call the patient and the family and we sit and talk to them. That's really important and essential also. Make sure that you ensure patient's privacy. Like we ask the patient, whom do you want to involve in the discussion? A lot of time there can be a conflict between the person and the in-laws party, and the patient does not want to discuss that in the presence of their in-laws. It could be even conflict between husband and wife, and they don't want to discuss in front of, we know there are cases like this. So we have to first check with the patient whom the patient wants to engage in, and then make sure that only those people who are really involved in the patient care should be engaged in the discussion. On your side, you could have your fellow doctors, maybe one or two. You could have your senior nurses who can handle especially the emotional outbursts that you are expecting. You could have a counselor, you could have a social worker if you have that in the system, because these people will help you in managing the emotional outburst or reaction that can come in. Things like facial tissues, glass of water, if you can arrange something like this, it always shows the human side, and it gives you a chance to kind of showcase your goodness to the patient. Like Jayapra was mentioning, that it's important to assess patients' starting point, because before you tell anything, it's important to know first how much the patient wants to know and how much the patient knows. If the patient has an idea, suppose if this patient has been referred by another hospital, patient has already undergone number of tests, that means patient already has an idea that this is what is my diagnosis. It could be that the patient has come for the first time and you have identified something serious, and now it's your turn to explain. So you will have to really stagger your information accordingly. When you ask them, what do you know about your condition, or what has your referring doctor told you? And these questions will help you in knowing how much the patient knows already. Patient's information need may vary. We saw in the role play, on one side, Mariam and Archana were saying that we wanted to know what it is. Why was the doctor not coming out with the clear word? On the other side, Neha said the word cancer really gave me a shock, because that was not something she was anticipating. So that means patient's information need can vary. Somebody might want to know every small detail of their diagnosis and treatment. Somebody might say, doctor, I don't have no idea, you know it better, so you tell me what is the treatment, best treatment for me, and I'm ready to go ahead with that. So it's important to check what is patient's information need, and accordingly we will have to customize the patient's information. If the patient does not seem to be prepared, for example, sometimes like Satyapal, he said, I was alone. We could have even asked, do you have anybody with you? And if the patient says no, I have come alone today, then maybe if you see you have to give some serious diagnosis or information, maybe we will have to reschedule and say that I think we have done some tests and we find that the report is not really very encouraging. It's better if you get your family so that we can discuss in detail. So it's always good to, usually at least in Indian setup, we see it's always the patient and the family who participate. Of course, as I said earlier also, we need to ask the patient. It is not always we straight away ask, whom do you want to engage in the information? Informally also, if you ask, when we discuss about your diagnosis and treatment, whom all do you want to be present? And that will give you an idea. If somebody, the patient does not want to be there, or particularly when somebody needs to be there, you will get to know. Now, coming to the patient's information need, actually studies have shown that most of the patients want to know as much as possible. Almost like 100% of the patient wants to know what is it and what are the options available. A lot of time, patient's perception has a huge role on the treatment and outcomes. Benign conditions can actually identify, can trigger extreme panic reaction, and sometimes the patient may have complete illness denial or wishful thinking or unrealistic expectation of treatment. I have never had anything like this in my family. I can't have it. So they may even completely deny, or they may say, Doctor, we have been coming to you for all this while and you have always treated us and sent us home. I'm sure this time also it's nothing very serious. But then we know there can be, difference in what happened earlier and what happens now. So those unrealistic expectations have to be not only identified, but addressed appropriately. You will have to come out honestly and correct the misinformation so that they know what it is. But if you see extreme denial, if you see patient really very anxious, then probably you'll have to tailor the bad news and involve some more family members so that the family can handle the patient and they can handle each other. A lot of time the family says, please don't tell the patient. It's very important to first of all ask them why they don't want to do it and what are their concerns. Usually I think they don't want the patient to be affected by it. That's the major concern. But it's important to help them know the benefits of disclosure. Why should the patient know? And then also, of course, we need to tell them that legally and ethically also it's important for the patient to know what their diagnosis is. When it comes to performance, of course, we have to be sensitive, but at the same time, we need to be straightforward. Please remember, when you will try to minimize the severity by, playing it soft, it can actually create vagueness and confusion. So then it can further create problems for you and for your team. So it's always good to balance between sensitivity and honesty. You can choose right words, you can stagger the news, but then the message should go very clearly. Of course, one should avoid precise answers and precise ranges. Kitna time hai? 6 mahine. I think that I'm sure nobody will say like this. So if I say usually in such conditions, patients live from 6 months to 1 year. So that means you are giving them a range. Or usually patients after chemotherapy and radiation are able to, manage 4 to 5 years. The family would know that, okay, we have this much of time. But then at the same time, when you don't want to be very, upfront with the information, idea is that we don't want to take away all the hopes and we want to give them, some reason to be optimistic. But at the same time, we have to remember that we need to give honest information. Otherwise, they will blame you for either hiding information or not coming out honestly. So when you are doing this, please make sure that you do not use any technical jargon. If you are using jargon, they will not understand and they may blame you for miscommunication. A lot of time we continuously speak and try explaining, and even if when they ask questions, I have seen doctors saying, let me first explain you everything, ask your questions later. I don't think that's a good idea. One, whatever their concerns are there at that moment, they need to be addressed. Second, their questions will give you an idea of, are they accepting it? Are they receiving it well? Are they understanding it? Are they really with you? So, and also when they're able to ask and explain and come up with their doubts, that will also give them a chance to express their feelings. So any monologue that, okay, let me first explain you everything and then we will take question answer, that's not really a very good idea. So therefore, I think in between we need to pause and rather ask, do you have any questions? What questions do you have any question is a very wrong question. The right way of asking it, what questions do you have about whatever I have explained you? That will give you give them an opportunity to think, okay, what questions do I have? So pause frequently. A lot of time just being silent, and of course your body language play a very big role in facilitating the discussion, in promoting the idea that this is a dialogue and not a monologue, and we are discussing, and they have full right to speak and ask questions and clarify. At the end, make sure that you check for understanding. A lot of time you would have explained everything, and in the end their question will be, Doctor Saab, ठीक तो हो जाएगा patient. And then you realize, okay, they have not understood. So in between, if you keep checking and clarifying, that shows that yes, and in the end, you can even ask them to repeat for you. That will give you an idea how much they have understood. I think we have discussed this part at length earlier also. Communication, words play very little role. Of course, they have to be simple, no jargon, easy to understand language. But at the same time, your tone of voice, speed of talking, pause in between, silence, body language, facial expressions, everything is making a huge communication. They are looking at you, and especially when the person gets to know something like this, it comes as a shock. So there's a cognitive, momentary, it's a cognitive deficit. They are not mentally there. Physically they are there, but it's a thought block for them. So they are looking at your facial expressions and tone of voice, and that is kind of helping them see what is your communication. So the body language that we need to associate with the discussion is, of course, we all agree, establishing eye contact is very important. A lot of time when we don't make eye contact or we avoid eye contact, what do you think the patient will see this as? But when we avoid eye contact and when we don't make eye contact, what can this be seen as?
Patient may feel that you are not confident, one thing. You are trying to avoid something, you are hiding something.
Absolutely.
And you are not interested.
Oh, yes.
Interested in this.
Absolutely.
Well-being.
So that there can be lack of confidence, lack of trust. You are hiding something, you are not, or maybe you have done something and you are hiding and you are trying to cover up. So at that moment, making eye contact with the patient is very, very important to communicate that whatever I'm saying with a lot of confidence and understanding. And also, I am with you in this, but I am not the one who has caused this for you. So that's the reason why you should be making eye contact, and your posture plays a big role. If you are sitting like this and talking, they will see it differently. And if you are rocking in the chair and talking like this, they'll see it differently. So leaning forward, making eye contact, nodding. So these are all good ways to kind of communicate that I am serious about it and I understand it's a serious situation. I am with you in this and we are going to work together on it. So when the patient wants to express or ask any questions, allow them to express, listen to them attentively, answer their questions with patience. There will be emotional reaction. They may start crying. You will have to give them time to get back their composure and, then restart your discussion. A lot of time they may also say something that might sound like they're blaming us for the outcome. I don't think we have to react to everything. Just listening to them also is okay. But if you see them coming, saying this repeatedly, that means that they have a doubt that we haven't managed it well. Then, of course, we have to address it. And first of all, ask them, what is their, why are they thinking in this way? And then you probably will need to explain to them and explain your stand on this. But we don't have to, react to everything that they say. And also, of course, verbally and non-verbally, you can comfort the patient and the family. Verbally, of course, we'll talk about it. Non-verbally, sometimes touching on the shoulder or on the head plays a role. But again, you need to see how far can the patient take it and what kind of rapport you have with your patient and how will they see this behavior. Of course, you will have to, in this situation, you will have to assess that. Now, body language that can communicate empathy, one is, of course, tone of voice. When your tone of voice is not authoritative, intimidating, or loud, and when you're slow and you are sounding more friendly and in terms of in counseling tone, they can see that you are being empathetic with them. As I said, eye contact, gaze, and avoiding gaze. Again, they can communicate empathy and antipathy. Silence, again, teary eyes. I mean, I don't know how many of you really are okay with the idea of teary eyes, but I have seen doctors becoming teary when they are talking to the patient and patient family. After all, everybody is a human being. You may endorse, you may not endorse, but I think there is no harm if you express your emotions. I mean, too much of suffocating your emotion is not a good idea. Of course, we need to have good control on the composure, but that also shows your human side, and they get to see that you are also serious and affected by it. Of course, we have to learn to regulate that and that facial expression, hand and body movement. We have talked about it in the previous session, so I'm not. But then these communicate empathy, leaning forward, touching the patient or the family member. In between, sometimes we sigh when we say that, yeah, I know it's very, very sad. And they can see that you are kind of affected by it. So it's not like you are affected, but actually, yet I am with you in this. That's the communication that the patient wants from you. So how do you normally start the conversation? If anybody wants to share couple of dialogues that you normally use with your patient. Dr. Jayapriya, I can ask you first because you are.
Yeah, I generally wait for them to ask me. I let them to lead the conversation to see where they're coming from. I don't immediately break. So I wait for them to ask and I see how much they already know before I wish to say something. Yeah.
Any particular dialogue you start with, like for example, you got the report, you got everything confirmed that this is, breast cancer.
So usually how I start is I start with the patient because patient would have come with some symptom. And many times what happened, we get so involved in the diagnosis with sharing reports that we will ignore that. So first it's always I asked, how are you doing today? And how was your pain? Or, I start off with that. So it depends. So some patients discuss the symptoms first and come here.
That's building connection. What you're talking about is building connection. After you have built connection, now you have to announce. So is there any way that you use, like for example, you say, I'm really sorry, I have to share something very, serious with you. Anything, something like this?
Usually, if it is cancer or something, by the time we come to the biopsy and the report, it's a journey. And by then, they would already they want to know if it's cancer or not. It's very easy. So if it is there, then I have to break it and say, what we were suspecting all along, indeed is come as positive.
Yeah.
Something like that. What we suspected is come positive. That's how I start. And then I pause and see, what they're going to say. Yeah.
So these are a couple of, sentences that I have written here. I'm sure you will have your own way of doing it. But I've seen people saying, I'm afraid I have a bad news to share. So unfortunately, the report is not very encouraging. Your MRI report actually shows very clearly, mass. So, I mean, I don't know how many of us can really you do it with this kind of a communication, but these are good ways to kind of show that you understand and you are also serious about the communication. But like you said, that you say that the report is not really good, so I must MRI report is not really good. So when you say something like this, it affects the patient and the family. Basically, bad news results into cognitive, behavioral, and emotional deficit. So therefore, you see patients literally in shock because they don't know how to react, how to respond to it. You can't change the news, but at the same time, how you handle that and how you communicate, that would actually decide how they will further take it. So studies have shown that almost 50% of the patients respond with shock. Almost the same number of patients have expressed that they were frightened. Of course, 1/4 of the patient reported being sad. 40% accepted. 10 to 15% also said that they were not really affected and they didn't care for it. But the patient can react by, say, maybe crying or suddenly become silent. Or they may ask you, are you sure? Is this my report? Could the report be wrong? Have you sent the sample to 2, 3 places? Have you got the sample checked by different labs? It is just one lab that you are basing your diagnosis on. So that means they are not, they are in denial. They want to be 200% sure of that. And they may also say, don't tell my husband, don't tell my wife, don't tell my parents, don't tell my family. So these are the usual reactions that you will see. So the whole thing is called dabda, that is a psychological response to the grief situation. That's called dabda. D is denial. When you will see them in shock and they will be denying and they'll most likely be saying, no, it can't be. There is something wrong. I think you are mistaken. That's not my report. Or they may also react with anger and being aggressive, where they will actually try to blame you for what has happened. They may say the previous doctor did not refer on time and therefore we lost time. I wish we had brought to you earlier, or I wish you had got this test done earlier. You did not take it seriously. I was telling you that this is something very serious. So they may be angry, they may blame you, they may be even revengeful with you or with the previous doctor or with any of the healthcare provider. Then the third stage is bargaining. Then ultimately they will start realizing that this is the reality and this is what is the situation. So they will bargain with you that, can we take the patient to another hospital? Can we go for a second opinion? Is there any alternative treatment available? Doctor, do whatever you want to do. I will pay you, I'm ready to pay any amount, but please save my patient. So these are nothing but they are trying to bargain and to save the patient's life. Once the reality sets in, you will see them becoming quiet. So they will look more like depressed and being quiet. And then finally they accept the reality. Now, how do you handle this situation is when they are in denial, it's helpful to share information and show them why you are very sure of what you are saying. So they will get to realize that you are not just basing your diagnosis or your opinion on your general understanding, but whatever you're saying is based on the test reports or whatever investigations have been done. When you find them angry or shouting or blaming you for what it is, it's important to stay calm, not to react to everything that they say. Usually it's more like, outburst and then they calm down. It's helpful to listen to them attentively and be supportive, but at the same time we need to be, we need to keep an eye to see where the anger goes. Usually, most of the times when you allow them to express their anger, they calm down. But if you see them becoming aggressive and over aggressive, then of course we have to handle it in a different manner. But usually once they start becoming calm after they have expressed their anger and they get into bargaining, it's helpful to help them see the reality. You have to be empathetic, because when they say we want to go for second opinion, of course you can encourage them and allow them to do that. But if they say that is there any alternative treatment, or they say that you take as much as money you want but save my patient, that's where you'll have to assert and help them understand that money cannot find solution for everything. Wherever we are right now, what option we have is to maybe reduce the patient's suffering and minimize the effect of disease on the patient. So that's where you'll have to help them see the reality. Once you see them accepting or becoming quiet, that is where you need to give them direction. Now what needs to be done, that will again come from you, because they will be clueless. Now what next? Where do we go? Who will treat? What are the options available? Maybe you don't have that setup where you will be treating this patient, so you will have to send the patient to another specialist center. So what directions need to be given, you will have to explain to them. Once you see them accepting that yes, this is what it is, and now I'm okay, let's start deciding now what needs to be done. That's where you have to encourage and appreciate them for participating in the treatment and care plan. Empathy, as I said, we have talked about it earlier also. Though it said that put yourself in their place and see how they feel, I think it's more to do with feeling in tune with the other person's feelings. If you can understand how they are feeling, even that is good enough, because it's not like I shared my experience that tuberculosis, which is nothing, even that kind of affected me mentally, that if it is tuberculosis, then what is my life, what is my children's life? Same way, if somebody gets to know they have cancer or they have HIV or they have some serious diagnosis, if I can see how it must be affecting them, I would be more understanding of their plight, and I'll be able to see their word, I'll understand their feelings, I'll not judge them for being panicking or anxious or not, or overreacting. I'll understand their feeling, and then I'll make effort to reduce that suffering and their pain. So there are many ways you can express your empathy. For example, when you say, I can see how upsetting it is, I know you were not expecting this, I'm really sorry, even I feel bad for what has really come out, but that's the reality. For anybody it will be difficult. So what you are trying to say, that yes, I understand it's a difficult situation for you, and I'm with you on this. That's what probably patients want to see coming from us, especially in the final hours when we know the death is inevitable and it's just a matter of few hours. I'm talking about like situation like ICU, where we know it's just a matter of few hours, and in many cases you can actually recognize, you would know that this patient is not going to make it. So there, I think communicating with compassion and honesty is very important, because there, there's not much that can be done. It is the family also who is well in the know of it. So in those situations, it's important to allow the family members to meet and see the patient, because probably these are the last few hours when they can see the patient alive. So being more understanding and supportive will play a big role, because they need support, and you need to see what kind of support they are looking for. And if you can improvise these small things, that will give them a relief in that moment, and also they will be appreciative of you are being more understanding and humane. When it comes to announcing death, again, as I said, try to do it in person. The senior most person should do. We need to be honest with that. And silent support, by being there, asking them if they have some cultural practices, rituals that they want to do, and if you can cooperate and participate and arrange for that, not participate but at least arrange for them, they will really be thankful to you for that. Especially when you need to talk about autopsy or about the funeral, again, we need to be very good with words and very sensitive when we are talking about something like this. At the same time, we need to be watchful of the unusual grief reactions, because this can lead to extreme aggressive reaction coming from the patient party. And of course, whatever support you require in that time and the patient require, we need to make sure that we are able to provide that. In these situations, because the breaking of bad news is done by the senior most doctor, there is a role for the residents, nurses, and other paramedicals. Especially, they need to be more understanding of the patients and families' need and those others. If we can be little more accommodative, they are thankful for getting that kind behavior. Now, this is one slide I thought I'll share with you. Usually, when you're breaking bad news, I think before breaking bad news, clinicians are more likely to be stressful. After you have done it and you see the patient's reaction, and if you see them accepting, then your stress would go down. But it is the family and the patient who actually start experiencing stress when they get to hear the bad news. So their stress, goes longer than our stress, and we need to be aware of this fact. As I said earlier also, it's not an easy thing. So, clinicians would be uncomfortable about their expectations, especially if the family is expecting an outcome that is very, very positive. So you are going to destroy their hope and also let them know the reality. There's always a feeling of being, inadequate in the face of uncontrollable. I think we all have recently experienced during COVID time when we were fighting with an unknown enemy. We didn't know what to do, what not to do, what will work, what will not work. So we feel inadequate and incapable of handling that situation. And a lot of time, there is a lot of emotional reaction coming from the patient party, and I have deliberately written anticipated. I've not written unanticipated. It's an anticipated emotional reaction. So we need to be prepared for it. We are usually not prepared for it. And that's where actually communication breaks down and there's an aggressive reaction. And a lot of time we have painted an optimistic picture, especially for procedures which are very, very small and minor. Just yesterday, I received a message from a patient who is known to me. He said, my nephew got his eye surgery done. He got his ICL done. It's one of the procedures for refractive surgery. So he said the patient got ICL done and they had infection. The patient had uveitis. The patient was put on steroids, and then after steroids, the patient has now developed glaucoma. And the patient is being treated both for uveitis and glaucoma. I'm sure when the doctor did the preparation for procedure, he must have not talked about all these things. Usually for these things, for even I know one of the eye chain in Delhi had this tagline for phaco surgery. घर से आइए, surgery करवाइए, office जाइए. That means come from home, get the surgery done, go to your office. You need not even go home. But I'm sure once they had, some nucleus drop or some vitreous hemorrhage, they must have realized that this is not something that makes sense. So we really need to be careful when we are actually, handling this situation. Please give realistic expectation. We have to accept professional limitation. We have to learn to control our emotional reactions. If you keep the family updated, you will experience less extreme reaction coming from the family. They mentally get prepared if you let them know the condition is serious. Whatever the likelihood is, they should know about it. And then also we need to, give very realistic expectation. Even small, simple procedures have serious consequences. So we can't say that cataract surgery or LASIK surgery is risk-free. No surgery, no procedure is risk-free. We have seen patients collapsing with test dose. I mean, I remember one of my friend and her husband who were in private practice, they gave a penicillin test dose and the patient passed away. Both of them were in huge trouble. They actually closed their practice immediately after that. They said, we'll do government job, we will not, get into something like this. So we need to be really, there is nothing called risk-free medicine. There's always risk. And then of course, the last point in remedies, whatever communication you do with the patient party, please document. So when you communicate what you document, and when you document what you communicate, you are on safe side. Now, once you have done this, we have explained, I think these are the common mistakes we do. One should, avoid doing that. One is that we avoid breaking bad news as long as possible. We try to postpone it. We think, okay, we'll see when to tell. Or some people don't do it at all, that hoping that somebody else will do. But again, that's not a good idea. Some of us are very economical with truth. So we either don't tell the truth or we lie. Again, it's very unsafe to practice something like this. And we sometimes do not pick patient's cues. We can see the patient is doubting, patient is not trusting, patient is not okay with whatever discussion we have, but we just avoid addressing it. We pretend as though we are not we have not noticed it. It's very unsafe again game. And a lot of time we do it in a mechanical manner. Again, you are taking a risk. If you are not emotionally connecting with the patient party, there's a risk they can overreact. So once you break the bad news, there is always a fear in the patient's mind that you are going to abandon them, we are not going to look after them. So at that point, I think it's very important to reassure them that they are not going to be left, because maybe you will have to refer the patient, you will have to send the patient to another center, but of course with after explanation. And in case if there are some current symptoms that need to be treated, we need to look after that and discuss the next treatment plan. And also in case if they want to come back to you for follow-up, or the patient needs to come back to you for follow-up, you establish that timeline. Also, if you're referring them, give them proper referral. If possible, give contact details to whom you are referring, so they know that if you have somebody known there, if you just tell them that, okay, go and meet so and so doctor, and if you just call and say I'm referring this patient to you, patient feel that I have been properly handed over to another center or another doctor. So these are this is like tying the point to point rules. So and also at this moment, if you are able to involve and engage people like family, friends, social workers, spiritual counselor, they will look after the part that sometimes we are not very comfortable handling, because these are all aspects of disease and death. So we need to make sure that we are helping them with that possible support. So just to quickly summarize whatever we have discussed, most patients want to know, and if done rightly, I think it improves our relationship with the patient. It will help you, your patient, and also the family to cope with the situation. It will foster your collaborative relationship with the patient, and it will prevent aggressive reaction coming from the patient party. So 6 steps that we have discussed. Please prepare yourself properly. Find out what the patient wants to know. Find out what the patient knows, and what the patient wants to know. Share the information in a more sensitive and honest manner. Respond to the emotions. Please notice that the patient has emotions to express, and we need to handle them. And then work with the patient in planning and follow. The last slide is from my side. Disease and death, they're very scary. I think we get to realize when we face them personally. I don't wish anything of this sort for anybody, but I think once we personally experience something like this, it really, really changes our view about life and death. So this is, I know I did it in a little hurried manner because it's already 10 o'clock, and I really needed to cover this. Any questions? Or rather, what questions you have?
Hello, ma'am. I have actually two questions actually specifically. The first one is as we have just seen, like the pandemics that we have come across, be it the wave 1 or be it wave 2. Now, particularly referring to wave 1, when no one had any idea about what's happening, and this is coming out of a personal experience, and we have faced this. In 2020, one of my relative, a distant relative, so he was admitted. He was a bureaucrat in Nagpur. He was a retired bureaucrat, and he was in Nagpur, and he was admitted for COVID. and there was a lockdown. There was a strict lockdown, and in Maharashtra, as you may know, the situation was really, really bad. So my mommy, he was my mama. So my mommy gets a call from the hospital. Uh, they they said just these words, and these words, my mommy, whenever she meets me, sometimes or the other, she always refers to this, that these words, they keep ringing my ear more many a time. कभी भी आते रहेगा. Those words were, सॉरी तुमच्या पेशंटची डेथ झालेली आहे. सॉरी आपके पेशेंट की डेथ हो गई है. These were the last word, and they hang up the phone. She did not had to go. She couldn't go there to the hospital. There was no information then later on after that, and yeah, and we did not even see him. She did not see him. So that was a situation in the first. So I don't know if at all we have a situation like this in this pandemic, and we do not know then how we could deal with such kind of situations. And so this was the first question I have. The second one I have is regarding, like, since I am currently working in National Health Authority, where Pradhan Mantri ji is very ambitious of having that universal health coverage, uh, and digitizing the system with Ayushman Bharat digital mission and everything, to connect the remotest people person in the rural areas. Now, once these digitizations has been done and all these applications, there is e-Sanjeevani again, 2.0. So we're all connecting, getting in that ecosystem of that digital platform. And now it would be even be possible in coming years that you would be the remotest area, the rural area person. He must be having, he is having a mobile phone. He'll get his reports on his mobile phone. And now, in case he does not understand and he wants to talk to a doctor, he will take the telemedicine platform. And on the telemedicine platform, then how do we communicate? Yes, I understand. We all spoke this because in a one to one, when in an offline mode. So when the things get digitized, how do we get prepared for these two specific situations? One is during that pandemic, and second is when the digital revolution actually happens. So these are
So,
my two.
I think pandemic was a very, very abnormal, exceptional situation. I think there is no doubt that none of us were prepared for something like this. We were really caught, unaware. So definitely, I mean, this kind of communication you would not expect, but and also at the same time, we know people who were in healthcare and who were actually doing their duty in the hospital. For them also, it was life threatening for them, because they were away from their family. They were in very, very extreme abnormal conditions, and it was hot summer, and they were wearing that ppe. And I mean, the videos that we got to see was really very, very painful. So I think in that situation, yes, if we have had some training, ultimately, see, it is the training that can help us learn. The discussion we are having here, I'm sure it will leave some impression in everybody's mind. And now onwards, when you will do this with your patients, at least you will be mindful of the fact that this has to be done little more, with little more care. Of course, everybody will implement it in their own way. But the task that I'm trying to do is, like we say in Hindi, is alak jagana. I can't teach and train anybody, but I am just making you aware and alert that this is something which is serious, and we should do it little mindfully. Rest, I think all of us have that power within us. If we were little more empowered, probably we would have done it in more sensitive manner. And but of course, we can give them the leverage that they were also not prepared for something like this. And we are thankful to the healthcare providers who at least did their duty, whatever they did, by at least attending to these patients. Some of us never came out of our homes. We were homebound, but they were exposed to the disease, and they didn't know whether they will be adversely affected, or they'll die, or they will come out of it. So we can give them that leverage. But of course, the training is the answer to it. Let us train them. Again, people working for telemedicine, they need to be trained. I did a couple of programs for 1MG because they have that telemedicine platform. So I did a couple of programs for them where they made me talk to the doctors and help them understand that it doesn't make a difference whether you are seeing the patient in person or you are attending the patient on any visual or audio mode. It is your communication. Like people say online programs cannot be run. I think this is what we have heard all this while. But you have seen it yourself that we all are interacting as though we are in one room. I mean, I just forget that we are actually virtually connected. I have a feeling that you're all there in front of me. So same way, if these doctors, nurses, and other healthcare providers can be trained to communicate effectively, I'm sure they will be able to do justice to whatever they do. Because without skill building, you can't do anything, whether it is digitalization or telemedicine. I mean, you require training and skill building. That is the only.
Maybe this, maybe in the coming future with AI in place, probably we can have a breaking bad news chatbot.
I don't think so. I don't think because I mean I would like to hear it from my doctor than hearing it from a chatbot.
Again,
But you never know.
probably the Gen
But you never know.
the Gen Z generation.
You never know. You never know.
You know.
I agree. Yeah. Thank you for asking both the questions. I think they were very relevant. Any other question if anybody has? I know it is 10 past 10. Can I request Mariam to make her presentation because we have one presentation by Mariam. If everybody can come in and if you can have your cameras on. Yeah. So Mariam, I'm allowing you to share your screen. This is, yes, you can. Go ahead, please. Yeah. And thank you, Dr. Siog, for insisting on holding this session. I appreciate your concern, and I think we did a good thing by not canceling today's session. Thank you.
Thank you so much, ma'am, and really thank you for all the participants who joined. Thank you, ma'am. Yeah.
Is it visible?
Yes, it is visible. Yes.
Yeah. Hi, I'm Mariam. I'm here to present about using video as a way of effective facilitation. So I would like you to see this video, watch this video. Please.
Mariam, please unmute. There is no voice. Pause and unmute. Mariam, you need to unmute your device first. Unmute your device. You're on mute mode.
Now? Now is it audible?
Let it be on and then let's, I think, play the video. Video is on pause mode.
I will share.
No,
Shall I do again?
No. You switch it on. Yeah, start again. Yeah. No, that means on the video itself there is a mute option that needs to be unmuted. Yeah, now I think it should.
It's not unmute. It's not.
Yeah. Yeah, do it now.
Now?
Let's see.
Now? Is it playing?
No.
Even before first, you need to enable the audio actually when you upload
Yes,
any
when I
audio
share,
file.
actually, when I shared,
Yeah,
I
you get that option. You'll get an option for saying enable the audio.
yes, I did that actually when like enable video and audio.
Actually, you can go to YouTube, and if you have the link, you can post the link there. Maybe if you will play the
But
video.
I think as Dr. Seo said, is my screen visible now?
No.
No. Again, I'll share. Let's see.
Yeah, you had stopped sharing, I think. Yeah.
No, but while sharing, usually it asks to enable the screen audio also, but it's not showing to me why.
My get maybe to select that. So share system.
So, Mariam, I think we can skip the video. You can share the video in the group, and
I
let's
can
get to the
can I present it in another like next session?
I think it's okay. Video you can share in the group. It's a very beautiful video. I have seen it. You have shared with me. I have seen the video and I liked it. You can talk about, you can discuss about the video as a pedagogy. And I think we are all familiar with video as a pedagogy because we have, but you have given good points in your presentation. Please go ahead and
Okay.
share the screen. Yeah.
Okay. Okay. Video pedagogy is the use of digital media for
On your screen.
facilitation.
Mariam, share your screen.
Your screen is not shared, Mariam. Start sharing again.
What happened, Mariam? Oh, yes. Now,
Now it's the use of digital media for facilitation. It's the valuable way for communicating information. It's a very versatile and powerful tool because it can convey the emotions and the body language and facial expression. And video is a very effective way to engage audience and capture their attention because we're naturally drawn towards visual content. Uh, why we need to use video in our facilitation, because it enhances the facilitation and it caters to the different learning styles, as it provides both auditory and visual stimulation, and it facilitates the understanding of complex and abstract concepts effectively, and hence better understanding and knowledge retention. As our attention spans are dropping, we it can bring the larger amount of content in a small content video. And it creates a memorable experience for the audience and have lasting impact. What are the best practices for using video? We need to use the video very strategically and align it with the learning objective. And need to keep the video short and concise, because the short video and good quality videos are more engaging than the long and the bad quality videos. and we need to provide the context and relevance to the video. And while choosing a video, we need to keep these 3 points in the mind. The cognitive load, like it need not be very long and very complex. So it will be like overwhelming experience for the audience. And then we need to keep in the mind of the participant, like we can pause the video and we can use like conversational language while the video is playing. And then we can ask and make it more interactive by asking questions. How can we integrate videos in our facilitation session? We can introduce it at appropriate times for introducing new topic or to reinforce key points, or to break the monotony of the like big lecture or like long session. And then we can facilitate discussion after watching video and encourage participants to share their thoughts and insights. And it can be used as a reflection. What we should not do while in the videos, like while selecting videos, it should not be long and complex, and it should not give any ambiguous or controversial or biased message. It should not target or show someone in the bad light. And it should not be in contrast to the socio-cultural practices. That's all. Good. Thank you.
Thank you.
I'll once again try if we are able to play that video now.
Babies this young
Yes.
are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm my girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Could you engage with the video?
Very good. Very nice. I have forwarded it to my daughter. My grandson is 2 years, so I thought she will find it useful. That how kids, they react and they need to be handled. Yeah.
I would like to add one disadvantage to the video content that it can happen. The technical glitches can happen.
Yes. So one has to be ready with the
That
backup.
is one of the yeah.
You should have always a plan B for such technical
Yeah.
glitches.
Actually, I had a plan B for this. Like one more link was there, but I think I forgot to, as Dr. Seo said, like audio, I forgot to click that.
If you can stop sharing,
Thank you.
each other.
Yeah.
Close. Yeah.
Thank you.
So any questions for Mariam on video as a pedagogy?
I'm going to show this to my daughter today.
I would like to know the feedback about the video.
Interesting. It's very
Yeah, she's 4 years old, and she had her birthday yesterday, so she's going to love this. Yeah,
I'm sure. Yeah. So I think if there are no more questions, we will close this session here. Thank you so much, everybody. You showed a lot of patience and cohesiveness and collaboration of deciding together, working together. So it's already 10:25. I'll not hold.
Dr. Mariam, are you working with children, with babies?
Yes. I work with mother and children, and I have 2 kids.
Good. So let's meet next Thursday. That will be the last session. So I'll be requesting all of you to maybe record a minute's video about your feedback of whatever you went like through the program. What was your experience? How did you find it? Do you recommend it to others? Or whatever changes you want to suggest. I mean, very honest feedback I'm looking for. Maybe a 1-minute video that I would post to others in case they wish to register for the program. So I'll share all that in the group. And good night. Thank you. Bye-bye.